Hello, and thank you for joining this OncLive TV peer exchange, which features expert insight on advanced prostate cancer. My name is Raoul Concepcion, and I am the editor-in-chief for Urologists in Cancer Care and the director of Advanced Therapeutics at Urology Associates in Nashville, Tennessee. Recent and emerging data are providing signals as to the benefit of early treatment in patients who have high-grade prostate cancer. In this panel discussion, my colleagues and I will be discussing the results of several studies that address questions related to treatment of patients with or without frank metastatic disease. We'll also discuss mechanisms of resistance to therapy and the potential impact of early treatment or sequencing of therapies. I'm joined today by Dr. Mike Fabrizio of Urology of Virginia. Mike is a professor of urology and the director of the Endourology Fellowship at Eastern Virginia Medical School. I'm also joined by Dr. Jorge Garcia, who is the director of the Advanced Prostate Cancer Research Program at the Taussig Cancer Institute and Glickman Urologic and Kidney Institute in Cleveland, Ohio. Dr. Judd Mowell is the James H. Siemens Professor of Surgery and director of the Duke Prostate Center Division of Urologic Surgery at Duke University Medical Center, and Dr. Charles Ryan, who is Professor of Medicine and Program Leader of Genitourinary Medical Oncology at UCSF Helen Diller Family Comprehensive Cancer Center in San Francisco, California. Thank you again for joining us today, and let's begin. So in this first segment, let's talk a little bit about a very hot item that everybody is sort of aware about, which is this concept of androgen receptor splice variants, and discuss recent findings as presented about the AR-V7 splice variant and response to taxanes in men with metastatic castration-resistant prostate cancer. Jorge, can you go over that data a little bit, which is sort of the Antonaracus data that's been sort of hot over the past couple of years now?
Sure, thanks Raul for the opportunity. So as a way of background, the initial data presented and published actually in the New England Journal of Medicine by Emmanuel basically was actually aimed to assess whether or not men with castration-resistant, metastatic castration-resistant prostate cancer who harbor a specific mutation in AR, specifically the splice variant 7, would actually predict for response or lack thereof to oral therapy with either enzalutamide and or abiraterone acetate. In their data, initially 62 patients actually were tested for this specific splice variant, and then patients went on to receive either enzalutamide and or abiraterone acetate. And the interesting findings of that data demonstrate that patients who harbor that specific mutation in the ligand binding domain had no clinical benefit whatsoever to either oral agent. More important than that, although I think this is one of its, probably the first of these kind of trials that we're looking for biomarker development in prostate cancer, one of the challenges of this data, as much as we all are excited with this, is the fact that how we actually got to detect that splice variant. In their data, initially, they actually look at circulating tumor cells, which is a controversial way of assessing men and as a biomarker for men with castration-resistant disease. But nonetheless, I think that data is powerful enough, in my opinion, that clearly demonstrated that if you have a splice variant 7, you're not benefiting from oral therapy. More important is the question whether or not that splice variant could predict subsequent response to a taxane-based therapy, and that's what Emmanuel presented at ASCO GU this year. And clearly, in his small sample size, 30 patients or so, who went on to receive cabazitaxel-based chemotherapy, and when you look at the data, clearly having the presence of that splice variant did not predict for that subsequent benefit or lack thereof to cabazitaxel. So I don't think that having or not a splice variant should actually be utilized to define who needs chemotherapy in that context.
So Chuck, what's the, I think it's important for the audience to understand that this CTC looking for the mRNA and the splice variant is not commercially available. And so from your perspective, what are the limitations of this right now, and what does the audience really need to take home about splice variants, measurements, biomarkers, et cetera?
That's the challenge. It's a very exciting story because it's a predictive biomarker, and heretofore we have not had that in prostate cancer at all. Assuming that it is validated and assuming that it becomes a commercially available test, it would be useful because it will prevent us from using an expensive therapy. It'll prevent us from wasting patients' time. But you highlight the very issues that remain unanswered, which is when is this test going to be available? How reproducible is it going to be? And keep in mind that a large proportion of CRPC patients don't have circulating tumor cells. And in fact, it could be that the very patients in whom we want to begin treatment with enzalutamide or abiraterone are those who would harbor a very low burden or zero circulating tumor cells. So even if this becomes commercially available tomorrow, there are still going to be questions that will remain about it. My understanding is that the original data came from an assay that was developed in Johns Hopkins, and they deserve a large amount of credit for developing that assay. There's a company that's developing a commercial assay as well, and those have been done in parallel. But it's for the practicing physician out there right now, it remains something they should know about, but it's not something they can act on, neither can I.